Okay, we'll get going, and this is the last day of TRACO for 2013, and after the first lecture, I'll give some announcements about the final exam. And so our first speaker today is Perwaz Hussain. He's in the Laboratory of Human Carcinogenesis, head of the Pancreatic Cancer Unit. For background purposes, he got his PhD in India. Then he trained as a postdoctoral fellow at the Swiss Institute for Research on Cancer. And subsequently, he came to NCI. And the title of his talk is Pancreatic Cancer, Current Understanding and Future Challenges. Perwaz.
Thank you, Terry, for the introduction. So what I'm going to do today is to give you a brief overview of pancreatic cancer and what we know right now, what is our current understanding, and what are the challenges that we are facing to improve disease outcome in the patients with pancreatic cancer. So let me start with this first slide, which shows some of the grim realities associated with pancreatic cancer. It's the fourth leading cause of death due to cancer in the United States. The median survival is less than 6 months, and the estimated 45,220 new cases and 38,460 deaths in 2013. So what you see here is that most of the people who are diagnosed with this cancer die within the same year of diagnosis. And the most frustrating part is that there is no effective treatment available for this disease. There has been almost no progress in the treatment of pancreatic cancer in last more than a decade. In 1997, for example, gemcitabine was approved over 5-fluorouracil because it enhanced the survival by more than a month. And then 10 years later, a combination of erlotinib, which is EGFR inhibitor, and gemcitabine was approved that enhanced the survival only for 2 weeks. 2 weeks. In 2011, phase 3 trial showed that FOLFIRINOX, which is a combination of 4 chemotherapeutic drugs, that is oxaliplatin, leucovorin, irinotecan, and fluorouracil, showed a good improvement in survival as compared to gemcitabine alone in the advanced pancreatic cancer patients. And that was from about 7 months to 11 months. So this 4-month increase in survival. However, it was highly toxic, and not a lot of patients could tolerate this. And recently, in October, Von Hoff and group showed in this phase 3 clinical trial that a combination of paclitaxel, that was albumin-bound paclitaxel, and gemcitabine improved survival in advanced pancreatic cancer. And here the toxicity was not as high as FOLFIRINOX. But again, if you see the improvement in survival, was about 2 months. And here, what they have done, they have exploited the increased expression of a SPARC protein in the pancreatic tumors, and albumin-bound paclitaxel goes and bound to a SPARC, and it is available to the tumor. So this is the current understanding or advancement in the treatment of pancreatic cancer. And as you can see that we have not made much progress. So as we know that poor therapeutic response and also late diagnosis contributes to the very low median survival in pancreatic cancer, and we don't have any good specific and sensitive biomarkers for early detections. And out of these, only about 18 to 20% of all the pancreatic cancer cases can be detected early, and if they are detected early, they can go for resections. And these resectable cases the median survival is about 2 years. However, more than 80% of these patients show recurrence within 2 years, and also you see that very small percentage of these resectable cases can survive up to 5 years. There are several clinical prognostic markers that predict survival in resected cases. For example, a stage, grade, lymph node spread, and resection margin status. However, we see that none of these prognostic markers are always consistent. Sometimes you see that patients with the same stage, grade, resection margin status, some die just 2 months after the resection, while some survive for 5 years. So one of the question is that does molecular differences in tumors determine patient's outcome? And then we will discuss more about this a little bit later. So how we can improve the outcome in pancreatic cancer cases? So one of the important thing to do is to have effective therapy, and the strategies that are being used to devise effective treatment is to identify novel targets, identify molecular subtypes, because maybe one compound may not work in all the pancreatic ductal adenocarcinoma, and there are some evidence to that. And then based on those molecular stratification, treatment can be selected. So will the selective treatment work? And also the drug delivery. And I will give you a couple of examples later on in my talk that some of the existing drug, they are not able to reach the tumor, and they have provided some evidence, although in animals and some of the early clinical trials, that if we improve the delivery of the existing drug, for example, gemcitabine, and also gemcitabine in combination of some of the molecular targeted drug, it enhances survival, at least in the mouse model. And also we need sensitive and specific early detection biomarkers, and biomarkers that will indicate the existence of precancerous lesions and not the cancer, because once the pancreatic cancer is developed, it's already too late. So all these can be achieved or require the understanding of tumor biology. So understanding pancreatic tumor biology is key to improving disease outcome. So let me talk a little bit about the biology of pancreatic cancer. First of all, this shows the progression model of pancreatic carcinogenesis. There are well-defined precursor lesions, and the most common lesions is pancreatic intraepithelial neoplastic lesions, or PANIN. They can be categorized in PANIN 1, PANIN 2, and PANIN 3 based on the degree of dysplasia and also atypia. And then PANIN 3 is carcinoma in situ. There are several established genetic alterations that occurs during the development of these precursor lesions to the malignant cancer. And the most common is the activation or mutagenic activation of KRAS, and also inactivation of P16, which is modified in about more than 90% of the cancers. And these are their timings. First, it's KRAS activation, and then inactivation of P16, and then P53 and SMAD4 or DPC4 are inactivated in about 50% of the tumors. And one of the interesting observation is that those pancreatic tumors that have SMAD4 mutation, they show a higher metastasis, distant metastasis in those cases. This slide shows the desmoplastic stroma, which is very prominent in pancreatic cancer, and it is one of the characteristic features. So this here you see cancer cells, and here is the stroma. A stroma has stromal cells and also extracellular matrix, and there are evidence of a strong interaction between stroma and tumor, and these stromal cells express a number of growth factors, chemokines, and cytokines, and seems to be involved in the initiation, progression, and also therapeutic resistance to the treatment. So the pancreatic cancer is highly heterogeneous. This is the work from Bert Vogelstein lab, where they have extensively analyzed about 27 tumors for genetic alterations. And what they found is that each tumor, in average, had about 68 genetic alterations that can be grouped in 12 core signaling pathways associated with cancers. However, in the two tumors, not all the pathways were altered, and also in each pathway there were different genes that was mutated in between different tumors. So this is the example which suggests that pancreatic cancer is highly heterogeneous. So one of the question is that, are there different molecular subtypes of pancreatic ductal adenocarcinoma? So pancreatic ductal adenocarcinoma is the most common form of pancreatic cancer. More than 90% of the pancreatic cancer is pancreatic ductal adenocarcinoma. So this study a couple of years ago in Nature Medicine have analyzed about 27 samples, and what they found that there are different molecular makeups among pancreatic ductal adenocarcinoma, and they classified it as classical, quasi-mesenchymal, exocrine-like, based on the on about 80 to 90 gene expression, and they also found difference in the survival among these patients, and classical type survived longer than quasi mesenchymal pancreatic ductal adenocarcinoma type. And what they also did, they did some very neat experiment in the cell culture, cell lines, which represented these types. And what they found is that one drug, for example, gemcitabine, which is a standard chemotherapeutic drug, was sensitive in one but not in other. And the same was true with erlotinib, that is EGFR inhibitor. So what they concluded that combination of these two drugs that are in fact not any effective in all different representative cell lines that was representing these different subtypes. So it is not wise to give the same combination in all the pancreatic ductal adenocarcinoma, and in future it will be worthwhile stratifying patients. And of course this study was small and it needs further validation in larger cohorts. So let me talk a little bit about treatment strategies to improve disease outcome. And one of the strategy that is being extensively studied is how we can improve drug delivery and enhances the effectiveness of systemic therapy. So in these studies that I'm going to discuss to you, they have used a mouse model of pancreatic cancer. So I would like to give you a brief overview of this model. So this model has a mutant KRAS and mutant P53, which is pancreas specific, that is activated when these mice are crossed with PDX-CRE mice, that is pancreas specific CRE recombinase, and they faithfully recapitulates the development and progression of human pancreatic ductal adenocarcinoma. So using the same mouse model, the authors used the inhibition of hedgehog signaling, which depleted stroma and enhanced drug delivery and also improved survival. So they used hedgehog inhibitor IPI 926, and when they used it in combination with gemcitabine, which is the standard care of drug, they found a decrease in the percentage of mice with liver metastasis and also the survival of these mice as compared to the mice which received only gemcitabine. Another very neat study is here by the same group who had developed this model earlier, Hingorani's group. And what they have found is that in the tumors there are increased interstitial pressure that is in fact compressing the blood vessels. And what they have found that it is because of the deposition of hyaluronic acid, increased deposition of hyaluronic acid. And what they did, they used hyaluronidase, that is pH 20, combined with the polyethylene glycol to enhance the half-life of this hyaluronidase. And what they found that it decreased the interstitial pressure and it enhanced the vascular pressure, and that drug could reach tumors. And what they saw again is increased in the survival of mice that received gemcitabine plus PEG-PH 20, and also decrease in the distant metastasis. And this compound has been tested successfully in phase 1A and B trial, and this is currently under phase 2. So now let me touch a little bit about inflammation and its association with pancreatic cancer, and that is my interest in our group. So what we know that chronic pancreatitis enhances the risk of developing pancreatic cancer, and if you have hereditary pancreatitis, then the risk increases more than 50-fold. We also see constitutively enhanced NF-kappa B signaling, increased expression of COX-2 and NOS2, and a number of different inflammatory cytokines that have enhanced expression and enhanced level in tumors and also in the serum or plasma of the pancreatic cancer patient. And also desmoplastic stroma, which I touched in the beginning, is highly inflammatory, and you see active inflammation there. So here we see that you see a stepwise accumulation of inflammatory changes, starting from normal pancreatic duct to the development of pancreatic intraepithelial neoplastic lesions, and then in the pancreatic ductal adenocarcinoma, you see the accumulation of macrophages, lymphocytes, neutrophils, activated pancreatic stellate cells, and which plays an important role in the development of inflammatory stroma. Recently, Craig Loxton at MD Anderson has shown that inflammation is also required to maintain an oncogenic level of KRAS, of mutated KRAS activity, and that is mediated by NF-kappa B pathway, and there is a feedback loop through the formation of PGE2 through enhanced COX-2 expression. So inflammation also plays a role in maintaining the oncogenic activity of KRAS. So one of the inflammatory mediators of interest we have is macrophage migration inhibitory factor, which is secreted by which is a pro-inflammatory cytokine, and it is expressed in a variety of different cells, including epithelial cells and also inflammatory cells. MIF mediates immune and inflammatory responses. It is also increased in tumors, several different tumors, including pancreatic tumors. It enhances ERK1 and ERK2, phosphorylation and activation of this pathway. It activates an FKA B pathway, enhances AKT phosphorylation, and also enhances NOS2 and COX2 expression. In addition, it inhibits p53 functions, and recently several investigators have shown evidence which suggests that MIF is a molecular link between inflammation and cancer. So what we did, we simply tested a hypothesis that MIF contributes to pancreatic cancer progression and predicts disease outcomes. So we first took the pancreatic tumor samples and the adjacent non-tumor samples. This is the immunohistochemical analysis showing the expression of MIF, and you can see there are increased expression in tumors as compared to adjacent non-tumor tissues. And then we also did mRNA expression analysis by qRT-PCR, and we found that enhanced a higher expression of MIF is associated with poor survival in human pancreatic carcinoma cases, and the MIF expression was dichotomized based on the median values. And by doing univariable and multivariable analysis, it was also found that MIF is an independent candidate predictor of prognosis. Then this observation was further validated in two different cohorts of pancreatic cancer cases, cohort 1 and cohort 2, and you can see that a higher expression of MIF, again associated with the poor survival in pancreatic cancer. So what is going on there in these tumors? So one of the processes that is epithelial to mesenchymal transition, we know that enhances malignant progression in pancreatic cancer. And recently, Rim and colleagues have shown that inflammatory microenvironment can enhance EMT and increase metastasis, and even pancreatic intraepithelial neoplastic cells, which are not fully cancerous, can attain EMT potentials under inflammatory conditions. So we tested the hypothesis if MIF induces epithelial to mesenchymal transitions in pancreatic cancer. So we used pancreatic cancer cell lines, which was stably overexpressing MIF, and as you can see here, CAPN2 and PANC1 cells. And what we found that MIF overexpressing cells had decreased E-cadherin here and increased vimentin expression. This is the qRT-PCR data, and these are the Western blot analysis. The same result was further visualized through immunofluorescent assay. Here, E-cadherin down and vimentin up. So what is going on? What are the mechanisms? So what we know is that ZEB induces, or ZEB family of transcription factor induces EMT, and it inhibits E-cadherin. Sorry about this. And we also know that MIR200 family members, they inhibit ZEB, and it induces mesenchymal to epithelial transition, and there is a negative inhibitory feedback loop between MIR200 and ZEB. So we tested the hypothesis if MIF-induced EMT is mediated through inhibition of MIR200 pathway. So again, what you can see that MIF overexpressing cells, they had reduced MIR200B and increased ZEB1 and ZEB2 expression. And when we re-expressed MIR200B, it restored epithelial characteristics in MIF overexpressing cells. Here you can see increased 200B, then you have decreased ZEB1, ZEB2, increased E-cadherin, and decreased vimentin. And the same thing we did by knocking down MIF, and what we found is that MIF knockdown increased MIR200B, E-cadherin, and decreased ZEB1 and ZEB2. So then we moved to in vivo models, and what we did here is took the MIF overexpressing cells. We first implanted in the nude mice subcutaneously, and we took the tumors, and we found that MIF overexpressing cells gave rise to enhanced tumor size and tumor volume. So we took a small piece of tumors and then implanted orthotopically in the mouse, and again we found that there was increased in the size of tumors. You can see here size and weight, and also metastasis was much higher in the MIF overexpressing tumors as compared to controls. And very interestingly, if you look at these two tumors, the control tumors were mostly well to moderately differentiated, but all the MIF expressing tumors were poorly differentiated. So we did the gene expression array analysis here, and we, as you can see, that MIF induced a change in global gene expression profile, and it showed a increase in vimentin, decrease in ecadherin, and increase in ZEB1. So MIF overexpressing tumors showed expression of EMT-related genes. So now let me come back to the genetic model of pancreatic cancer which I described. So we further tested the hypothesis by using this genetic strategy, and as you can see, and it is called KPC mice because of the KRAS, P53, and CRE combinations, and we generated MIF knockout KPC mouse model. Here you can see the tumors arising in KPC mice have increased MIF expression, and obviously in the MIF knockout mice you don't see that. What we found is that MIF deletion in these mice enhanced the survival of these mice. So this is an ongoing study, and we are examining the biochemical and molecular pathways that could be involved with these observations. So in summary, a higher MIF expression is associated with poor outcome in pancreatic ductal adenocarcinoma patients. MIF induces EMT in pancreatic cancer cell lines. MIF enhances growth and metastasis of tumor xenograft in mice. And MIF deficiency increases survival in KPC mice with lethal pancreatic ductal adenocarcinoma. And MIF may be a candidate target for designing improved treatment. So what we are doing right now is using a small molecule MIF inhibitor in the same mouse model to see that after they develop pancreatic cancer or the early stages of pancreatic cancer, whether MIF inhibitors or the combination of gemcitabine and MIF inhibitor has any effect on the survival of these mice or reduction in the metastasis in these mice. So I will come back. This is my last slide. I will come back to this slide and to conclude that we do not see much progress that can be brought to clinic currently where patients can be benefited through either novel target approach or molecular subtypes, treatment selection or drug delivery, but all these have provided promising data in the recent studies. And also, so there are many studies that have shown some of the promising biomarker for early detection of pancreatic cancer that will definitely help at least in enhancing the survival in these cancers. So I would like to stop here and thank you all for your attention and take your question if you have any. Thank you very much.
So cyclooxygenase inhibitors prevent EMT transitions. Are they effective in pancreatic cancer?
So they have not been tested yet. And the same goes with the NOS2 inhibitor. That NOS2 inhibitor or COX2 inhibitor is not tested in clinic. And my thinking is that NOS2 inhibitor and COX2 both have the clinically tested inhibitor, and that should be tested, both either singly or in combination with the existing drug.
Any other questions? Okay.
What was the early detection? Can you tell us something more about the current status on the early detection and the best outcome?
Yeah, so right now what is used is CA19-9, carbohydrate antigen 19-9, but that is only effective maybe in 70% of the cases, and also it is a detection marker for other cancers, and in about 10% of the patients who are Lewis antigen negative, this is not expressed. So this is not a good marker for detection, but it is a good marker for monitoring the treatment response that is being used. But unfortunately, there is none other than that which has shown good promise in the clinic. But there are many in the pipelines.
From the symptom and patient side, is there any sign and maybe possibly predict some problem with the pathway?
Yeah, one is the early onset diabetes, and the only screening that can be done and is being done at Hopkins in several studies, that following up the members of the family who have pancreatic cancer, and they have successfully identified many of the kindreds who were followed up with the endoscopic ultrasound, and their neoplastic lesion was removed. So currently that is the only scanning that is being done, because there is no symptom other than jaundice and diabetes and weight loss and
Pancreatitis.
and of course people with chronic pancreatitis and hereditary pancreatitis, they have increased risk, and they are also screened for that.
Okay, we'll be moving on then.
Great, thank you very much.
Okay, at this point, I'd like to make some announcements, and I'd like to thank Bob Wiltrout and Jonathan Wiest for financial support for this course. I'd like to acknowledge Jeffrey Steele in Building 50, Susan Skidmore up at NCI, at the Frederick National Lab for the various help in the presentations up there. And the final exam will be posted probably tomorrow, and you'll have up to 1 month to take the exam. And it's a multiple guess exam. It's not that hard. It's open book, open notes, but you need to get 70% of the answers correct to pass the exam. And then when you pass it, you'll receive a certificate signed by our scientific director in the month of January. So our last presentation for this year is by Dr. Dobrovolskaya. It's on nanotechnology and pancreatic cancer. Unfortunately, she couldn't be here today, but we'll be showing you through modern technology a prior presentation that she made to this class. Okay, so this is the last TRACO lecture for 2012, and I'd like to acknowledge Bob Wiltrout and Jonathan Wiest for supporting the course, And for audiovisual, we have Jeff Steele here in Building 50. We have Joy Jackson in charge of the videocasts, and Susan Skidmore up at NCI Frederick. And we'll make an announcement about the final exam at 5 o'clock. But our first speaker today is Marina Dobrovolskaya. She's a senior scientist in the Nanotechnology Characterization Lab up in Frederick. Her title, Immunological Properties of Engineered Nanomaterials. Marina. This can go in a pocket.
Okay, I don't have pocket. Thank you, Dr. Moody, for the introduction. Good afternoon, everyone. I will talk about immunological properties of engineered nanomaterials, but before we talk about the nanoparticle interaction with the immune system, I would like to give you some general overview of nanotechnology, because many of you who are dealing with cancer may ask, why I came here to learn about cancer, why do I need nanotechnology, and what is nanotechnology? Then I will give you a very quick overview of the immune system for those of you who are not familiar with it, and I will dedicate this significant portion of my talk to reviewing nanoimmunology and specifically talking about nanoparticle interaction with blood components and their effects on immune cell function. We will also have time to talk about preclinical characterization, and this is the main effort that is undertaken in our lab, the Nanotechnology Characterization Lab, or NCL. If you have any questions, we will have the time at the end of my presentation to go through them. For those of you who watch this presentation online, if you have any question, it is my understanding you will not be able to ask this, but please feel free to email. You can use my email at marina.nih@mail.nih.gov, or you can simply email it to Nanotechnology Characterization Lab, ncl@mail.nih.gov. So what is nano? There is no general consensus about what nanoparticle is. What you see on this slide is the definition from the National Nanotechnology Initiative that defines nanoparticle as particles with size between 1 and 100 nanometer. What you see on this scale of different objects, starting from the water molecule and up to tennis ball, is the size of different molecules and objects in a nanometer. And if we follow this definition between 1 and 100 nanometers, then we are talking about this range between the glucose molecule and the virus. The other sources like ASTM International defines nanoparticles as particles with objects with a size between 1 and 100 nanometers that may or may not possess size-related properties. And U.S. Food and Drug Administration defines nanoparticles as anything that is less than 1 micron. So as you see, there is the discrepancy in the different definition. And then later, I will talk about the immunocompatibility of particles. I will show you the examples how particle size influences their biocompatibility. So you will see why the size is why it is very hard sometimes to set up the cutoff, 1 to 100, or should it be 1 to 200, etc. There are a lot of nanoparticles in our daily life. Many of you may know, and many of you may use these products without knowing that they contain nanoparticles. There are more than 800 products on the market that contain nanotechnology products that include clothing and wound dressing and sunglasses and sporting equipment. Some nanoparticles like titanium oxide and zinc oxide particles are included as component in translucent sunscreens. There are liposomal or nanoemulsion particles that are very common in cosmetic, and carbon nanotubes are used as structural materials. Nanoparticles are very attractive drug delivery platforms for cancer. And the reason for this is because many of you know that cancer drugs are hydrophobic, and nanoparticles may improve their solubility and act as the carriers for the hydrophobic drugs. Also, the nanoparticles may offer multifunctional capability, in that what you see on this cartoon is that the particle is like a carrier which can be used to deliver a drug and an imaging agent and targeting agent all at the same time. Particles also, there are a lot of examples in the literature where nanoparticles and nanotechnology is used for the diagnostic purposes to decrease the volumes of the sample and improve sensitivity of the assays, which would allow earlier and more accurate detection of cancer biomarkers. How targeting with nanotechnology is achieved? There is a phenomenon that is known as EPR, or enhanced permeability and retention. And the main principle of this effect is that the neovasculature around the tumor is leaky, and that leakiness allows nanoparticles, due to their small size, enter through this blood vessels, enter the interstitial space around the tumor and stay there. And because particles carry drugs, and drug would be released and delivered into the cancer cells. There are two different terminology. We are talking about passive targeting. Passive targeting meaning that the nanoparticle does not have any specific ligand that would make it specifically deliver to the cancer cell. And this passive targeting is based on the EPR effect. But the second type is so-called active targeting. And active targeting includes examples where particles contain on their surface special moieties, which could be antibodies such as Herceptin, small molecules such as folic acid or cytokines, to allow them to interact with cancer cells more specifically. Now, it is general consensus in the cancer nanotechnology at the moment that even though you are trying to target nanoparticles, in order for active targeting to take place, you still need passive targeting. You still need the APR effect to allow particles to cross the blood vessels and get in close proximity to cancer cells. Now, let me very quickly go through the immune system, and the reason why we are interested in the interaction of nanoparticles with the immune system is for the patient safety. Because when we develop nanotechnology platforms, we need to make sure that the chemistry is there, then the particles are efficacious, but we also have to worry about potential toxicity and side effects, which is commonly known for many drugs, not only nanotechnology-based formulations. So the immune system include three main organs: thymus, spleen, and bone marrow, and two liquid tissues, lymphatic and blood. Lymphatic includes adenoid, tonsils, pyropatches in small intestines, the appendix and large intestines, and lymph nodes that, depending on their localization in the body, are divided into cervical, axillary, and inguinal. Blood is made approximately 50 to 60% of plasma, and another 40 to 50% is represented by cells. Plasma is mostly water with dissolved minerals, gases, and proteins. There are 7% in the volume of the plasma, 7% of plasma is represented by proteins. Of these proteins, half are albumins, another 40%, approximately 40%, are globulins, 7% fibrinogen, and the rest of the 3,000 proteins represent only 1% of the plasma. The main cells in blood include thrombocytes, also known as platelets, erythrocytes, also known as red blood cells, and leukocytes, also known as white blood cells. And leukocytes can be divided into granulocytes, which include neutrophils, basophils, and eosinophils, and agranulocytes that include T cells, B cells, and monocytes. And I also want to mention that this is very top-level differentiation between these cells, because each of the cell type, like T cells or B cells or monocytes, include a subset or multiple subsets, sometimes multiple subsets of the cells. There are two principal differences between blood and lymphatic. Blood is bidirectional closed system, and there is no separation between left and right. And lymphatic is a unidirectional system. It always goes in one direction, from interstitial space into the lymph node and into the blood. It is an open system. There is no circulation like we know with the blood. And the left and right side are separate. Why it is important is when if someone conducts biodistribution studies with nanoparticles and wants to detect particles, to understand whether particles travel to the lymph nodes, if the particle is injected on the left side, then the lymph nodes should be analyzed on the left side, not on the right side. Nanoparticles can be immunotoxic, but this immunotoxicity is either good or bad depending on whether it is desirable or undesirable. And I will explain you what I mean by this. Nanoparticles are engineered to be used for the cancer immunotherapy, to increase vaccine efficacy, to quench inflammation-associated disorders. So in this case, they are either immunostimulatory or immunosuppressive, but this immunostimulation and immunosuppression is wanted or desirable. And most of these examples come from engineered nanomaterials. But at the same time, there are many nanomaterials present in the environment that may cause hypersensitivity reaction, anaphylaxis, coagulopathy, or be immunosuppressive. These effects are not intended, but we have to monitor these effects. And this majority of the bad or undesirable immunotoxicity data about nanoparticles come from environmental studies. What we do at NCL, we are interested in engineered nanomaterials which are intended for cancer therapy, and we are interested in whether or not these particles have undesirable immunotoxicity, so that we can monitor any potential and predict any potential side effects to the patient. It is now generally accepted that nanoparticle physicochemical properties such as charge, size, hydrophobicity, and presence of the targeting moieties determine their interaction with components of the immune system. As I mentioned earlier, nanoparticles can be immunotoxic, but so far there is no new, when I say new, I mean specific to nano immunotoxicity was reported. Nanoparticle-based pharmaceuticals are not more intrinsically immunotoxic than other drugs in current clinical use. There are increasing number of examples when incorporation of the conventional pharmaceuticals, the small molecules or macromolecules, onto nanotechnology-derived platforms help decrease immunotoxicity of these conventional drugs. And here I would like to show you just one example. There are more examples, but I would like to use the anti-cancer drug paclitaxel. There are two forms of this drug currently on the market. One is nano formulation known as Abraxane. This is paclitaxel bound to nanoalbumin particles. And there is a traditional formulation of the paclitaxel, which is basically paclitaxel in the Cremophor EL. Then traditional formulation, the Taxol, and it was used in, it is used in the clinic for many years now. It is known that it causes hypersensitivity reactions, and patients have to be pre-medicated with immunosuppressive drugs before administration of this formulation. And this formulation have to be given through the slow infusion. And nevertheless, about 2% of the patients develop hypersensitivity reactions. Abraxane, on the other hand, when it was used in clinical trials, was administered through fast infusion. It did not require pre-medication, and hypersensitivity reactions were very rare and almost not existent. You may know that some of the hypersensitivity reactions common for hydrophobic drugs are attributed to activation of the human complement system. And this is not a real allergy, it's called pseudo-allergy or complement activation-related pseudo-allergy, or CARPA. So what we can, what I will show you on this slide is this interactions with complement system can be monitored in vitro. And what you see here is the complement data, the Taxol formulation that that was associated with CARPA reactions in patients in clinic activates complement in vitro, and the Abraxane formulation does not. What this data tell us is that when we develop nanoparticles, we can use in vitro assay and screen nanoparticles in vitro for their potential to activate complement system and compare the potency in terms of the complement activation of a given nanoformulation to drugs that are currently in clinic, such as Abraxane and Taxol, to understand whether it is physiologically significant, if there is activation. And we use this data not to discourage nanoformulations from further development, but to inform our clients, people who develop the nanoparticles for cancer therapy, about potential side effects so that they can proceed with preclinical, clinical development of these formulations with caution if there is activation of complement. Now, let's talk about the particle interaction with blood components. And I would like to use in this and the following slides few examples to show you how particle physical-chemical properties such as size and charge influence their compatibility with components of the immune system. The dominant cells in blood and the first cells that that nanoparticles faced after IV administrations are erythrocytes. The particle size is very important. What you see on this slide is example of the PAMM dendrimers. This is polymeric nanoparticles. They're also known as artificial proteins because they're, the globular soft particles, very monodispersed material. But if we use particles with the same surface charge, we see that the small particles do not damage erythrocytes, but large particles do damage erythrocytes. And what we detect on these slides, we detect leakage of hemoglobin from damaged erythrocytes. Now, if we use the particles of the same size, but with 3 different surface charges, anionic, neutral, and cationic, we see that only particles with cationic charge, but not their anionic and neutral counterparts, interact with erythrocytes and damage them. Thrombogenicity is another very important hematocompatibility problem, and nanoparticles can be thrombogenic. There is increased concern about the disseminated intravascular coagulation, which is associated with administration of certain types, not all, but certain types of engineered nanomaterials. There are the challenges with studying DIC or other coagulation disorders and particle interaction with components of coagulation system is the multi-component nature of this system. So first of all, we have this key element which is called PCA, procoagulant activity. Monocytes, endothelial cells, and some cancer cells, then they are activated, can express this PCA complex on the surface. This PCA complex is made of the lipid phosphatidylserine and the protein tissue factor. Then both of these components are present on the cell membrane. It serves as a platform for recruitment of the plasma coagulation factor and eventually triggers plasma coagulation cascade leading to the blood clotting. On the other hand, we have the thrombocytes or platelets. Platelets are then in the non-activated states. They're like discoid cells. They're very small cells, about 2 microns in size. And when they are activated, they develop pseudopodia, and then they aggregate, and they also release a lot of the secondary messengers that promote activation of platelets and other immune cells. And again, eventually this leads to the blood clotting. Particle interaction with platelets also depends on the particle size and surface charge. Similarly to hemolysis data, what you see on this slide is that particles with identical surface have different effects. Small particles do not activate platelets, and large particles activate platelets. And this is, for those of you who don't know how neither work with platelets, this is the cells in the resting condition, and this is how they look when they are activated and they form these aggregates. Particle surface charge is also important. Particles with the identical size by different surface charges have different properties. Amine-terminated, positively charged particles activate platelets, while their anionic and neutral counterparts do not. And for dendrimers are very good model to study also role of the surface groups, density of the surface group on the particle surface. The reason for this is that the synthesis of these particles is very well controlled. Not always it can be achieved. There are many particles. There are iron oxides, there are carbon nanotubes, there are emulsions and liposomes, and dendrimers fortunately have the synthesis of dendrimers is so well established that we can control the number of the surface group on the particle surface. What this data show that if we increase density of the surface amines, then the platelet aggregation increases as we go through the lower density to the higher density of the particles. I mentioned to you in the previous slides, that the leukocyte procoagulant activity is another important component of coagulation disorders that are observed, that are common complications in cancer and sepsis, and also which are associated with administration of certain nanoformulations. And what we see here is that, again, particle size and the surface charge could influence induction of this procoagulant activity. In case of the cationic dendrimers, as the particle size increases, the induction of the procoagulant activity increases. And again, the particles with anionic and neutral surfaces do not induce procoagulant activity complex on the cell surface, while cationic particles do. And again, the surface, the density of the surface charge are important, as increasing the density, we increase procoagulant activity. Complement system is another system in the blood that particle interact with upon IV administration. And complement have two different functions. First, its first function is non-specific clearance of pathogens, but undesirable and overwhelming activation of the complement is also responsible for the hypersensitivity reactions and anaphylaxis. On the other hand, complement activation is needed for the humoral cellular immune response, because complement is now known to enhance antigen-presenting cells and T cells and B cells in the activation stage of these cells and how they respond to the antigen. Then it comes to nanotechnology-based pharmaceuticals. It is now generally accepted that 10 nanoparticles are intended for IV administration or for systemic administration. Then the complement activation should be avoided in order to avoid these undesirable side effects. However, the nanoparticles administered through different routes, such as subcutaneous or intradermal routes, complement activation actually may benefit, and this activation is used in vaccine development field. Activation of complement, unfortunately, is a dose-limiting toxicity for pegylated liposomes. But it is important to recognize that it depends on the polymer conformation and the terminal groups. What you see on this slide is clinical data showing that the individual patients, the white bars is the complement level of the complement terminal complex before injection of the Doxil, and then the black bar shows level of this terminal complex after 10 minutes after administration of the Doxil. What is also known through the recent studies that liposomes that bear hydroxy-terminated PEG are less reactive with complement, while methoxy PEG is more reactive. So that for people who develop nanoparticles for cancer therapy, this is very important, because we are trying to avoid particle mediated complement activation, and therefore we should use linkers and the PEG, which is unreactive with complement. On the other hand, people who develop nanoparticles for vaccine delivery may use complement activating PEG in order to achieve better vaccine efficacy. It has been shown that the methylation of the phosphate oxygen moiety of methoxy-PEG, decreasing particle size to 20 nanometers, and then selection of the linker may all lead to decrease of the nanoparticle-mediated complement activation. Then particles enter bloodstream. They interact not only with complement and with cells, but they face complex environment of the proteins. And as I mentioned in the beginning and in the introduction, right now there are about 3,000 proteins in human plasma. What is known that particles which have unprotected surface, unprotected means it doesn't have hydrophilic polymers, it possesses certain charge. These particles bind a lot of protein, and therefore, very quickly after administration, they are sequestered by the organs of the mononuclear phagocytic system, such as liver and spleen. Particles which surface was protected by hydrophilic polymer, one of the examples, polyethylene glycol, bind less proteins, and these particles stay in circulation longer. So this is depicted on this slide by this red color. There are also examples that particles coated with polysorbate bind plasma proteins, but the dominant protein in this protein corona is apolipoprotein E, and these particles were shown to preferentially be taken to brain. Therefore, there are ideas that polysorbate or ApoE targeting of the particle surface may help delivering particles and drugs carried by these particles into the brain. Surface modification with PEG results in lower protein binding, and what you see here is the results from in vitro and in vivo studies of the colloidal gold particles. The anionic particles that do not have polyethylene glycol bind more proteins. Each of the spots on this gel is individual protein from plasma, and by transmission electron microscopy we can also detect accumulation of these particles inside of the macrophages. In vivo, then these particles are injected, and this data were generated by Giulia Pacciatti at Cytomune Sciences. These particles very quickly accumulate in the liver and spleen, and because these particles aggregate, you see the color of these organs changes to almost black. The same size particles, but coated with polyethylene glycol, bind less protein. They are not retained by macrophages in vitro, and they are not retained by liver and spleen in vivo. Particle size, charge, and conformation of surface polymer determines the uptake by mononuclear phagocytic system. In general, what was shown with various particles, that particles with size between 50 and 200 nanometers that do not have any coating, and especially if their surface charge is cationic or anionic, these particles are cleared through Kupffer cells in liver. Particles coated by polymer in so-called mushroom configuration, which refers to the less dense coating on the particle surface, provides some protection. Particles that have brush configuration, polymer in the brush configuration, which refers to the more dense higher density of the polymer in the particle surface, are protected from hepatic clearance. But even if you use this protective conformation but increase particle size from 200 to 300 nanometers, then these particles will be preferentially cleared by the red pulp cells in spleen. And if we increase particle size even further beyond 300 nanometers, regardless of the surface coating, these particles will not be protected and will be recognized and removed by the mononuclear phagocytic system. There is a very common question is, what routes, how do nanoparticles are taken up by macrophages and dendritic cells? And there is no single route. It is also very hard to study particles uptake because often it requires modification of the particles with fluorescent dyes, and then we attach fluorescent dye, we may change particle properties. But on this slide, I show you an example from our study that we did in collaboration with Professor Africa Gonzalez in Spain, where we used unmodified gold nanoparticles, citrate stabilized gold, with two different sizes, the 50 nanometers and 150 nanometers, and through series of experiments we showed that these particles can be phagocytosed, and specifically the uptake is mediated by scavenger receptor and can be suppressed by siRNA or by scavenger receptor neutralized antibodies, but also that the same particles are taken up via pinocytosis, specifically via clathrin mediated and caveolin mediated pinocytosis. And most importantly, if we block one route of entry, particles will go through the other route of entry. So it is impossible to block all routes of entries of the particles. Routes of uptake, as I mentioned, are determined by particle physicochemical properties, and those developing vaccines and nanoparticles to carry antigen use mannan or glucosamine chitosan modification of the particle surface in order to deliver these particles from the mannose receptor. There are examples in the literature that some of the fullerenes could be taken up through the Fc gamma receptor, and some of the lipid particles from the complement-mediated phagocytosis. But this is very interesting data suggesting and showing that the iron oxide particles and colloidal gold nanoparticles are taken through the scavenger receptor. Why it is important is because particulate uptake from mannose Fc gamma and complement receptor is accompanied by pro-inflammatory response, while scavenger receptor, the role of this receptor mainly to remove damaged cells and self-antigens, and therefore uptake through this route does not result in pro-inflammatory response. So some nanoparticles like metal oxides and gold colloids, when they enter through this route, they avoid particle-specific antibody, particle-specific immune response. What happens after particle internalization? Well, it is general consensus now that the biodegradable particles are cleared, they are destroyed by macrophages. But non-biodegradable particles accumulate inside of the cells, and some of them may accumulate for the very long period of time. Then Kupffer cells, for example, in liver, then Kupffer cell dies, then the particles are released, but then they are picked up by the new Kupffer cells, and this process goes again and again and again, so the particles may stay in liver for the long time. And this raises concerns about long-term safety of the nanoparticles, non-biodegradable nanoparticles. It is generally unknown right now about how if we use multifunctional nanoparticles, how components of this nanoparticle is processed within the cells. We don't know if they are stable or if they separate, if biodegradable and non-biodegradable components processed together individually, and also the antigen presentation of engineered nanomaterials is also not very well understood. But since traditionally the uptake and by antigen presenting cells is accompanied by presentation of the antigen and generation of antigen specific immune response, many groups have looked at the nanoparticles antigenic properties. Can nanoparticles induce formation of the particle specific immune response? What is known right now is that there are some research-grade engineered nanomaterials for which antibodies were successfully generated. And these materials include C60, C70 fullerene derivatives, single-wall carbon nanotubes, PAMAM dendrimers, and liposomes. The reason why I have this red star here, that in order to generate antibodies against these particles, researchers had to conjugate particles to a protein carrier and then inject these particles in the presence of the strong adjuvant, like Freud's adjuvant. If the same particles were administered without protein and without adjuvant, there was no particle-specific immune response. There is no data that would show that engineered nanoparticles approved for clinical use would result in antigenic immune response. There is no data that would show that engineered nanoparticles carrying therapeutic protein would result in anti-nanoparticle immune response. There is no data that would show that engineered nanoparticles carrying therapeutic proteins would result in anti-therapeutic protein immune response. However, there are data with colloidal gold nanoparticles and some liposomal formulations of the recombinant proteins that would show that this formulation do not result anti-therapeutic protein immune response, and moreover, they protect therapeutic protein from the recognition and from attack and clearance through the existing antibodies. So this is very important, and this is very encouraging data, especially for those who develop protein-based therapeutics. However, right now there is a very big problem in the biotechnology industry, people who develop therapeutic proteins, in that antibody response, patients' antibody response against therapeutic protein is a common problem. And pharmaceutical companies spend a lot of money modifying proteins and trying to prevent antigenicity of the therapeutic proteins. the recent data showed that some of these formulations are contaminated by particulate material. And these are not engineered nanoparticles, they are accidental particles. There is little understanding about the quantity of this particle, about their size, but the glass fibers, cellulose fibers, tungsten, silicone oil, rubber, stainless steel, and fluoropolymers were all named to be contaminants in therapeutic protein formulation. And one of the ideas of how these particles may enhance formation of the anti-therapeutic protein antibody is by inducing protein aggregate and formation of this larger protein complexes and formation of the repeated moieties of the protein on the particle surface that are recognized by the immune cells. In my opinion, it is very important to distinguish between engineered nanomaterials and nanomaterials used for the nanomedicine development and these accidental particles. There are two sets of data currently about the anti-nanoparticle immune response. These data allow us to say that for some nanomaterials, such as fullerenes, carbon nanotubes, and dendrimers, mature immune response in form of the immunoglobulin G is observed, and this is through the T-cell dependent mechanism. On the other hand, the liposomes, anti-liposome immune response is immature. There is no IgG, there is IgM response, and this formation of these antibodies are independent of T cells, but they heavily depend on the presence of the TLR ligands, especially contamination or specific targeting to the nanoparticle by TLR ligands, such as lipopolysaccharide or CpG DNA and other common moieties. Accelerated blood clearance was reported for some pegylated liposomes, and it was attributed to the formation of the anti-PEG antibodies. This was earlier studies, and now there is most recent studies that demonstrated that it depends on the terminal groups of the PEG, in that the PEG-thiol and hydroxy-PEG are not antigenic, not immunogenic, but methoxy-PEG and butoxy-PEG are antigenic, and specifically butoxy-PEG is very strong, provides very strong antigenic response. So it is very important to select appropriate PEG in the synthesis procedure in order to avoid particle recognition by the immune system and generation of the anti-particle or anti-PEG as component of the particle immune response. So then I was talking about this undesirable antigenicity. It is undesirable because we don't want to have this, then we use nanoparticles for drug delivery. On the other hand, antigenicity of common antigens is maybe enhanced by some nanoparticles through their adjuvant properties, and this is a good property, and this is a property which is used in vaccine field. What you see on this slide is examples of the particles in basic research, different polymers and lipid and colloidal particles and fullerenes with different size and different model antigens, different routes of administration, but the result was always the same. If you link antigen, model antigen, to a nanoparticle or co-administer it with nanoparticle, with certain type of nanoparticle, you may enhance immune response, or you may use lower dose of the antigen to generate comparable level of immune response. And some of these formulations are very successful. They are in clinical development, such as MF59, this ICOM and ICOM matrix. This MF59 is approved in Europe, but it is not approved in US, and these two other adjuvants are currently in clinical trials. One of the ways of how particles may enhance immune response is through induction of cytokines. And what I show you on this slide is example of the in vitro and in vivo correlation for the inflammatory cytokine interleukin-8. Nanoparticles that induce interleukin-8 in PBMC of healthy donors in vitro also induce IL-8 in animals. Then these are lipid nanoparticles. And in this case, these particles, they had nickel. And if you know, there is a nickel-responsive element in IL-8 promoter. So in fact, in this case, the IL-8 induction was attributed to the nickel component of the particle. But I would also like to bring to your attention, then you study cytokine induction by nanoparticles. It is very important to keep in mind that there are many obstacles. For example, chemical impurities, such as synthesis byproducts, are often responsible for cytokine induction and inflammatory response associated with nanoparticle administration. What you see on this data, on this slide, is carbon nanotubes that contain metal impurities induce IL-8 and TNF-alpha, but then they are purified from metal contaminant, then there is no induction of inflammatory cytokines. Bacterial endotoxin is another common culprit of the cytokine induction observed for nanoparticles. It is a very common problem. And for those of you not familiar with endotoxin, let me just mention that it is component of the cell wall of the gram-negative bacteria. It's a lipid it has a lipid A moiety, which has fatty acid and the disaccharide backbone, and then polysaccharide chain. And it is very potent immunostimulant. There are a lot of studies that show that particles may induce cytokine induction, but then endotoxin is purified from these particles. There is no cytokine induction. So we have to be very careful, and we have to always test nanoparticles for the presence of endotoxin. The common challenge in preclinical characterization is that many particles interfere with one or more of the traditional Limulus amoebocyte lysate assay, which is commonly used for detection and quantification of endotoxin in research and also in pharmaceutical formulations. All examples that I was presenting to you in the previous slides show immunostimulatory properties of nanoparticles. Immunosuppression is another type of immunotoxicity which should not be overlooked. Like other types of toxicity, it can be good or bad depending on whether it is wanted or it is undesirable. Here you see only few, and there are many other examples. The nanoparticles are either specifically designed, meaning their surface was modified to be immunosuppressive, to treat scar tissue, protection from sepsis, protection from ischemia reperfusion injury, prevention of allergic airway diseases, or also nanoparticles are used as a carriers for immunosuppressive drugs. Again, because these drugs are hydrophobic and they are insoluble, and nanoparticles serve very good as very good carriers for these particles. But for us, we are concerned about bad, undesirable immunosuppression because it may lead to decrease in host resistance to pathogens in cancerous cells, and may also lead to myelosuppression. And in cancer, cytotoxic oncology drugs, they are immunosuppressive already. So then we test formulations of these drugs. We want to make sure that the carrier drug is not immunosuppressive, the carrier of the drug, the nanoparticle platform is not immunosuppressive. And also, ideally, we would like to see decrease in the myelosuppression caused by the cytotoxic drugs due to the incorporation of the nanoparticle platform and achieving of the targeting to the cancer tissues rather than distribution to the bone marrow where it is not needed. Again, most of the data about particle interaction with the immune system are generated based on the models of blood. And there are fewer, just a handful data about particle interaction with lymphatic and lymphatic drainage. I would like to show you, this is a study that was done by the group in Germany that shows very well that the particle size is critical. Then small particles administered subcutaneously, then they drain into the lymph nodes and distribute to the lymph nodes, and they activate immune cells, the dendritic cells in the lymph nodes. But the large particles with the same surface properties do not, due to their large size. So what this data shows is that for those who develop vaccines, it is important to use small-sized particles in order to achieve efficient delivery into the lymph node, where the particle has an optimal environment for interaction with antigen-presenting cells, stimulating immune cells. Preclinical characterization. As I mentioned to you, all particles that come to our laboratory have to go through comprehensive screening of their physicochemical attributes. We have toxicology, and we also look at the particle interaction with the immune system to select candidates that are that have very high immunocompatibility profile, and to remove potentially dangerous and reactive nanoparticles from the further development process. We have this in vitro assay cascade that includes testing for sterility and bacterial endotoxin. We look at the hematocompatibility, and we look at the immune cell function. And all of the assays could be found on our website, and you can, by clicking on each individual assay, you can download full text and then use this protocol if you are interested in the specific protocol which you don't run in your lab. The common challenge in preclinical characterization is that many particles interfere with traditional assays, and there are two main interferences. There are false positive interferences that lead to false positive results, and there are interferences that lead to false negative results. And it depends on the really depends on the individual assay, on the assay readout, on the individual particle. For those of you who are interested in reading in more detail, I would refer you to this review article in Molecular Pharmaceutics. It is also important to understand nanoparticle immunocompatibility not only in vitro systems, but also to have some support from in vivo data. And this is achieved through in vivo studies using the single dose acute toxicity studies that my colleague at NCL, Dr. Steve Stern, is conducting. If this study reveals any issue specific to immune system, then it is followed up by additional immunotoxicity testing. And then also we are using selected immune function tests such as CFU-GM, which is a very common test to test drug formulations and nanoparticles for immunosuppression. This is local lymph node proliferation test, which is common immune function test used to detect hypersensitivity potential, and the T cell dependent antibody response to the TDAR assay that is used to evaluate nanoparticle immunosuppressive properties. And just to give you a flavor of the uniqueness of the nanoparticles, I would like to review this one of the in vivo methods. This is a local lymph node test. The traditional test is known as LLNA, local lymph node assay. And there is a version of this test known as local lymph node proliferation test. The idea for this test is the same. You have the test article, you administer it into the animal on 3 consecutive days, then you let them to rest for 3 days, and then you inject radioactively labeled thymidine, and then 6 hours after injection, you collect draining lymph nodes and look at the leukocyte proliferation. If there is leukocyte proliferation, the test substance is immunostimulatory, and this test is used to screen for the skin sensitizers. But this test is most commonly used in cosmetics. Nanoparticles, most nanoparticles do not cross intact skin barrier. Therefore, this format of the test is not applicable. It would give negative result, even though particle may be immunostimulatory. So this different version of the test, LLNP, is used because here, instead of the topical application, particle is administered through the subcutaneous injection. So that the only difference between two tests is the route of administration. But this test is what is advisable to use for nanomaterials, while LLNA is prone to false negative results depending on the particle type. So in summary, nanoparticle interaction with the immune system is determined by particle physicochemical property, in that charged cationic and anionic particles are more reactive than neutral particles. Immunotoxicity can be good or bad depending on the nanoparticle intended use. The common type of immunotoxicity that are reported or emerging for nanoformulations include cytokine-mediated reactions, complement activation, coagulopathy, and exaggeration of endotoxin responses. Common problems in early preclinical testing include endotoxin detection and removal from nanoformulations, nanoparticle interference with traditional in vitro assays, lack of standard toxic reference material, and also need for improved versions of traditional in vivo tests. And there is a huge need for reliable in vitro tests due to the cost and often limited quantities of engineered nanomaterials available early in development stage. I hope that I provided you the very general overview, because I was told that the auditory will include people with different backgrounds. Will include physicians and chemists and biologists and immunologists. But for those of you who are interested in more detailed information about particle interaction with the immune system, you are welcome to contact me by email. Or I also would like to offer you this resource. This book will be published in end of this month, like next week, or in next 2 weeks it should be released. It is available pre-order for Amazon and Barnes & Noble. It's 850 pages of information, including overview of the literature and also experimental approaches and detailed protocols how to study particle interaction with the immune system. And just as a disclaimer, I am the editor and the author of this book and several chapters of this book, but I have no royalties from the sale of this book. So I'm just offering it for you for informational purposes. So thank you very much for your attention, and if we have time to take a few questions. Yes.
From this screen, it could be more how a fullerene or a carbon nanotube may activate these cells. Since there are no biodegradable, how they can be presented to be activated? Is because maybe macrophages can release interleukins to activate the T cells, or is directly an effect from the T cells?
Well, there are, so the way right now, there is no, so far there is no receptor that was described to be like specific to nanoparticles. Like, like TLR, for example, TLR4 recognizes endotoxin. So it was very attractive to suggest that there is some TLR or any other pattern recognition receptor that would be specific to certain moieties of the nanoparticles. To my knowledge, there is no such receptor described so far. But what I showed you, these models about the T-cell dependent and T-cell independent antibody response. So what that referred to is the generation of the particle-specific antibodies. Let me go to this here, to this slide. And so what this model suggests is, this is hypothetical model. What this model suggests is then we inject just the particles. There is no antibody response to the particles. But if you conjugate particles to protein carrier, then B cells have repertoire of the receptor, which is so broad it can recognize virtually anything. But the amount of number of the cells with that receptor is very low, so it's not enough to generate significant immune response. However, when you attach particle to the protein carrier, the particle is being recognized by the B cells. Then the peptide, the protein is digested, and the peptide is presented to the T cells. That results in activation both of the T cell and induction of the cytokine and of the B cells that lead to the,
Basically, we're using the nanoparticle as an activant there.
Yes, yes, yeah. Yes, they are not, yes.
There are no antibodies direct to the nanoparticle.
Yes. But you can generate nanoparticle-specific antibodies if you attach particle to the protein. It's the same system with the haptens. They are not antigenic on their own, but you attach them to the protein carrier, then they become antigenic. And in this example of the T-cell independence, so these experiments were done in athymic animals, and they still have anti-liposome immune response. If you try to generate fullerene and CNT, the other nanoparticle-specific antibodies, then particles bound to the protein carrier in athymic animals, you achieve nothing. So this is why the T-cell and thymus is important. But for the liposomes, people reported a generation. There are multiple papers reporting generation of the liposome-specific antibodies in athymic animals. But in all of these cases, they had to have either LPAS or some ligand, immunostimulatory ligand, in order to generate the immune response.
Do the cancer cells alter these immune responses?
This is a very good question, but as I mentioned, even on this stage, just with a healthy immune system, this is very dark area. So there are very few, like handful studies. So there is definitely, for those who are doing basic research, this is a very good area to go because there is, there's plenty of work to do. But when it comes to cancer, then it's even like next level of complexity. I don't know any study that would address this question.
That'll do it. Thank you.